Hi, this is the Kinetic Chain Evaluation presentation for ATTR 810. My name is Beth Neal, and this is a class that is part of the Doctor in Athletic Training program at Indiana State University. One of the things that we have been studying this semester is especially lower extremity evaluation diagnosis, and we've kind of worked our way through the lower extremity, starting at the lower leg and then working up to the knee, hip, and pelvis area. And so this week's going to be kind of a culmination of any gaps that I identified in my literature or in my evaluation of a person who has a lower extremity injury. And it's supposed to be all encompassing. And so one thing I want to start out with is one thing I have a problem and have a harder time connecting with is when patients come in and will be like, oh, I have this injury or I have that injury. And I know that this is at least nothing that I could find studying, but whenever a patient comes in with this, I know most people think, okay, good, at least I have a way to start, but I kind of check myself and I'm like, okay, well then why'd you come see me? And have a little bit of an issue with that, and it sometimes honestly turns off my view of the patient, which is unfortunate. But now that I'm working PRN, I really don't know my patients very well because I go around to different sites all the time, and so whenever a patient comes up to me with this, at times it almost seems like they don't want to value my opinion as a healthcare provider. They maybe had to come see me because of coach, or know they can't get treatment if they don't come talk to me and let me do the eval. So I know that that's something I want to continue to work on, is my attitude toward patients in those situations. Another aspect of my evaluation that I want to continue to work on is history taking. So I did a study or like a little exercise with some of my students in class where I had them take a history, and they didn't know they were being timed on it, so they just thought it was just a regular history. And during that time, it went super fast, and so a lot of the evals were decently completed history taking, but just kind of go through and get what you need done. And I find myself doing this as an athletic trainer now. I haven't been certified for that many years, but I have enough years of experience under my belt that I will see a patient come in and I'll know kind of what's going on before I let them tell me everything. And I think that this can do a huge disfavor to my patients because I can miss some key aspects or some key points that they may be telling me through the history. I also think the history is where it takes your evaluation from cookie cutter to caring more about the patient through the disablement model. So when I'm looking at the patient and I come in and they are describing what I think is more of a common injury, I then will probably shut off a little bit more of that disablement model aspect of the patient of, do I care about what their impairment is? Do I care about what is causing this injury? And then what does that do to their life? And I think that that is something I really want to take more time on. I have a little bit of trouble, like I said, I'm going to connect this a lot to PRN, and I don't think the patient should get any less care. But I find it hard when I will be the one evaluating the patient and then will never have a follow-up with that patient probably. So you take all this in mind. You may try to document as best as you can, which PRN is very hard to do. And you want to show the athletic trainer that works there full time that, like, hey, these are issues that are going on for our patient. But I feel like a lot of times these get neglected. And that's something that I definitely want to continue to work on and try to figure out ways that I can better incorporate it rather than coming up with more and more excuses. Another issue I know that I am not very good at doing is posture analysis, and there's a ton of literature out there that shows how important the link is from the lower extremity injury to noticing, like, how does a patient sit, how does a patient walk, what does a natural progression for this patient look like, or what would an abnormality be. And as I know with PRN, I don't know the patient, so some of those things that you may take for granted, I can't do as a PRN athletic trainer. And I think anyway, no matter if you are or aren't, that you are giving your patients a disservice when you are not checking those things. So a lot of times how I think of posture analysis with the lower extremity is the patient will come presenting with an injury. Maybe they'll come in with a knee injury. And a lot of times, specifically with injuries caused by overuse, the knee may just be where the injury shows. So we may be dealing with a hip pathology or an ankle pathology that is therefore adjusted how the patient's going to walk, how they're going to run, and so I have now done a disservice to them by not looking at their posture. I think one of the biggest issues that I have in my clinical practice as far as a gap are the psychological defects. I had a really, really good relationship with the counseling center at Hardin-Simmons, and so I was able to easily refer patients over. So if a patient had a career or a season-ending injury or career-ending injury, I always would offer the career center to kind of talk with the patients outside of what I could do. And I think that that's really important for those patients, but I also think that there's a large amount of what we can do as athletic trainers. And I think some of the areas that I really notice the most with is maybe injuries that we don't deem as severe but can alter their life. So somebody who has some sort of lower extremity injury that maybe will not hinder their sport participation or just a little bit, but even if they miss a week, what that could do with them thinking on the disablement model of, okay, now maybe they are going to lose their starting spot, which isn't a huge deal to someone like an athletic trainer, but thinking to the patient like that could be their scholarship, that could be their livelihood, that could be their identity. I also always at this point think about issues such as like if the patient has to walk because they don't have a car and they have to walk from their house to campus and they now are on a boot or in crutches, what that can do to them also. And I don't think it's a lack of caring. I think sometimes it's just a lack of paying attention to smaller details or realizing what our patients need and what they have going on in their lives. And I think, like I said, I think that this is definitely an interprofessional collaboration opportunity, but I think it's also something that I need to get better with. I feel like I can connect to people really well, but I don't always feel like I'm very good at reaching out with sympathy or empathy or having that more emotional connection with patients that I think that they sometimes, or certain people especially, really need within the injury. These are a list of the references that I used within this talk, and a lot of the points that I said came from it, as well as from my own personal injury evaluation. And I definitely think I'm going to take the action of what I did, be more in depth with my patients, connect on them, try to really figure out who they are, because it's kind of more like a doctor's appointment where they're coming in and they don't know me, and definitely looking at the patient as a whole and not just either from an injury or what that injury does to their team.